having leg pain. I can see psychiatrists. I think I'm crazy. 37 years, I've never had any pain in my legs. I get an X-ray and now I'm so a lot of people are walking around with these things and no symptoms. So, and if you have acute symptoms, you can try to treat them conservatively and see if they get better. No one ever died in physical therapy, but people do die in surgery or from surgery. So you have to respect those things. You have to make sure that it's a last resort and that you can definitely make the patient better, or in your mind you can make the patient better. Otherwise, you're not doing anybody any favors. And then deformity, scoliosis. Not everybody with scoliosis needs surgery. Just because if their X-ray shows scoliosis, we see patients that are 60 years of age who come to us for one thing or another, and we get an X-ray, and they've had scoliosis since they were 11 and never knew it. So not everybody needs surgery, but if they have neurologic deficits, severe pain, then you consider surgery. The other thing that can cause pain is compression fractures, and these are common in elderly patients who are osteoporotic or with high energy injuries. And again, our workforce is aging. People have to work into their 60s and 70s and 80s. And if you're doing that and you're moving things around, it doesn't take very much trauma for a compression fracture. Now, a compression fracture essentially is, if you see the shape of your vertebral body, you bend down, it's sort of an axial force, and the force from one vertebral body to another crushes the one in the middle. And that's a broken bone, and so that causes back pain. You can get the pain from the actual broken bone, and you can get pain because once you break this bone, then you're kyphotic. You're like this. So your muscles your muscles, which were originally balanced, are no longer balanced. You can get muscle pain as well. And again, osteoporosis, just a quick definition, is a quantitative bone disease. It's not, and there's different types. There's type 1 and type 2. With primary, this is patients who are elderly or postmenopausal, and then secondary, if you're on taking steroids, endocrine disorders, renal. So very common. Osteoporosis is very common. And so are compression fractures. Now, the risk factors for osteoporosis are age, being skinny. It's the only time that being skinny works against you. Caucasian, recent weight loss, family history, or history of smoking, caffeine, and alcohol use. Common locations are in the middle thoracic spine, and then at T12L1. Managing these is mostly pain control, but the most important principle is prevention. Make sure that your patients understand that they are, as they age, they're at high risk of osteoporosis and having compression fractures. So you have to treat them. Either it's smoking cessation, weight-bearing exercises, take their calcium, and then there are multiple drugs that are released by pharmaceutical companies that supposedly improve your osteoporosis. And then we get DEXA scans to look at the severity of their osteoporosis, the presence or the severity of osteoporosis. Now, once you've had a vertebral compression fracture, the treatment is early mobilization. It's not laying around. Those are the old days. Now, even if you're in pain, we get you up and moving quickly. Pain control, preventing deformity either with a brace or other ways. And then resumption of normal activities and return to independent activities of daily living. Again, we use bracing, but a brace is totally tolerated in elderly patients. And then rehab. One procedure that we do is we'll take cement and inject it into the vertebral body to give structural support. Now, this was actually invented by one of my fellowship mentors, and the patients are osteoporotic, so they have weak bones, and then you're putting cement in between weak bones. It's like putting a rock between two eggs. What ends up happening with this procedure is that if the patient lives long enough, the level above and the level below also break as they push against cement between them. But patients are in pain, and you explain these things to them, and if they're willing to go through the risk, and I send them to a radiologist who does it. I don't do vertebroplasties, but a lot of the radiologists do. The surgical, so this is an X-ray post-operatively, and you can see cement in a vertebral body between two native vertebral bodies. Any questions?
What about synthetic discs?
Artificial disc replacements, you mean? So artificial disc replacements they were designed, and all the FDA studies and most of the marketing was done exactly where I did my fellowship at Texas Vacuum Institute. So I put in a lot of artificial discs. Originally, the reason that they were invented is that, again, I started the talk by saying that we're very efficient, and there's a reason why we have all these discs. And so what they've noticed is that when you fuse a vertebral body, when you fuse one vertebral segment, what ends up happening is the energy that is supposed to go through that disc is going to level above or level below. So you're just transferring the stress to level above or level below. And at 10 years, they found that 30% of patients will have what we call adjacent level degeneration, or arthritic changes in those levels. And so they thought, well, how can we prevent that? Well, let's see if we can just maintain that motion in that vertebral body by putting an artificial disc in. Now, unfortunately, after about 10 years, they realized that they really did not prevent adjacent level degeneration. And insurance companies are not willing to pay for artificial disc replacement. Now, I think we're confident, but the problem is if you're not doing a lot of them, then you stop doing them altogether. And so I don't do any artificial disc replacements in the lumbar spine anymore. I did a lot